this week we saw the first published research using our future health data. It came out sort of at that sort of nebulous time of midnight, so you could say it came out today. It's about the relationship between chronic inflammatory conditions and psychiatric conditions. Tonight, we're particularly pleased to have an international perspective on the panel, as we'll hear from the All of Us Project's Chief Medical and Scientific Officer, Dr. Geoff Ginsburg, about their project in the USA. And some of the questions that may be explored tonight in the discussion, I suppose, are, what information is necessary, desirable, and appropriate to give participants about findings that relate to their genome, in particular, and to their genomes in aggregate. And when and how is it appropriate to contact participants or to recontact them to offer them the option of participating in further studies? And how might this differ from established practices in medicine and research? Also, the question of polygenic and integrated risk scores may come up, and how they should be handled, given that they're significantly different from more traditional forms of genetic and genomic data. And then thinking about the patients, how best to give them the information and to minimize distress to them, but also we need to think about disruption to the health system as well, while seeking to achieve the project's aims. So there's really a lot for us to get our teeth into. So I just have one last resource to flag to you before we get started, which is a TEDx talk, From Genomic Data to Genomic Knowledge by PET's very own Deputy Director, Sandy Starr, which I would highly recommend that you watch. So our first speaker this evening is Professor Sir John Bell, who is Chair of Trustees at Our Future Health. He is President of the Ellison Institute of Technology, Chair of the Gates Foundation's Scientific Advisory Committee, and founder of the Centre for Human Genetics. Previously, he was President of the Academy of Medical Scientists, Chair of Oxford Academic Health Partners, and Regius Professor of Medicine at the University of Oxford.
Hello, I'm Sir John Bell. I'm the chairman of Our Future Health. And I think it's a really important time to reflect on the impact that Our Future Health is likely to have on our healthcare system, but also on the wider success of almost all global societies who are currently under pressure from a huge healthcare burden associated with the major chronic diseases. When we set up Our Future Health, it was intended to be the first global cohort of scale that would allow us to look at the way we can use prevention, early diagnosis, and early intervention to flatten the morbidity curve from many of the major common chronic diseases: heart disease, stroke, dementia, respiratory illnesses, renal disease, hepatic disease, obesity, diabetes, all the diseases which are so prevalent in most Western societies and which are becoming much more prevalent in developing societies. So that has proved to be the North Star for the project that we've done. And it looks now like we have got the numbers in Our Future Health data set that will allow us now to start to undertake the studies that are going to be necessary to understand how you do prevention and early diagnosis at scale in a population to make a material difference to the outcomes. So the next phase, and we currently have about 2.5 million people consented for Our Future Health, and we'll be headed for 5 million. We do want now to think about how we use the resource to interrogate the different interventions that can be used. We want to understand better how you can use a whole new set of therapeutic tools to manage disease before people become symptomatic. And that's why having a population between 18 and 101 is crucial, because we can find people who are just beginning to get the disease but don't have symptoms, and we can see whether the interventions are likely to be effective. Now, there's a whole host of new interventions that could be useful in this space. There's the usual methods for reducing uh, serum cholesterol, for reducing blood pressure, but also the new class of drugs, the GLP-1s that are associated with reduction in body weight and dealing with the overall problem of obesity. And so those, along with things like adult vaccines and other interventions of the kind, are likely to have a profound effect on our ability to increase health span in a population rather than lifespan. And that should be the goal, I think, of many of the things that we're doing. The other dimension here is to try and understand how we can diagnose many of these diseases earlier. So as we all know, diagnosing cancer earlier is the best solution to making sure that you can cure the disease. And there's a whole set of new paradigms that we can put in place to make that work. And we hope, alongside some of the exciting therapeutic developments, that we could get to a world where most people with cancer are being diagnosed when they have stage 1 or stage 2 disease. So this is an exciting possibility because no one else in the world has the asset of our future health to be able to do those studies. And I think we're uniquely positioned here in the UK to undertake those studies and to see if we can change the whole way healthcare is delivered. Now increasingly focused on prevention, early interventions, and early diagnosis of disease. That should make a massive difference to the health of the population at large, and also to the sustainability of the NHS.
The next speaker is Dr. Cosima Gretton. And Cosima is from Our Future Health, where she is the Executive Director of Digital Health and Deputy Chief Medical Officer. Prior to working at Our Future Health, she led programs at NHS Test and Trace during the COVID-19 pandemic, and she was a contributor to the book Human and Machine Learning.
As many people on this call will be aware, there are enormous public health challenges around the world. As you can see, we have, like in the UK, we face very similar burdens from increasing late-stage chronic disease compared to many other countries around the world. There are over 26 million people in the UK who live with at least one long-term condition. And by the age of 70, people will have an average of 3 long-term conditions, and the burden on both the health system and the economy is substantial. It's impacting our ability to work. Over 1 million people are not working because of various conditions, mental health conditions in particular. And 36% of people have long-term health conditions, even when they do continue to work. And of course, this further drives inequalities and impacts unequal health outcomes. Those from the most deprived areas or certain ethnic groups have basically get long-term conditions 10 to 15 years earlier, spending longer in ill health. We have, despite many advances in healthcare and a lot of money spent, we have failed to improve quality of life. And in fact, healthy life expectancies have also stalled. And part of the reason for this is that there's been too great an emphasis on understanding, diagnosing, and treating late stage disease. So I'll just, next slide. So the current model of care is really indexed towards that late stage disease. As you can see here, for example, 50% of cancer diagnoses end up in A&E, and there are about 2.5 million people after that point living with cancer, and that's projected to rise to 4 million. And there's about 100,000 admissions in the UK each year due to heart attacks and cardiovascular disease. And that costs UK taxpayers £19 billion a year. And when it comes to something like dementia, as you can see, which is even a later stage, we have no means of detecting or preventing it. The cost from this is expected to double from £20 billion to which was about a couple of years ago, to £55 billion by 2040. So as you can see, we have a substantial problem. It is not going away, and it is getting worse. So what does our future health aim to do? Well, we aim to be the research platform that enables the development of evidence that will generate a new model of care centered around precision public health. So shifting that focus from reactive managing disease once it presents to early diagnosis, disease risk prediction, improved health screening, and with that, early intervention and prevention. And this transformation is now feasible due to breakthroughs in data science, genomics, and diagnostics. So I'll talk briefly about these here. We don't have time to go into all of them, but these are some of the technologies that are emerging that our future health hopes to enable to catalyze research within that enable us to shift that model. So, for example, polygenic or integrated risk scores, which take general risk across the genome to predict someone's chance of a disease over time. You have other examples, such as in the early diagnosis bucket, you've got circulating tumor DNA, which offers a window into early cancer development via non-invasive liquid biopsy. And then, of course, you have early therapy. So you have therapies that are there to control the risk, such as long-acting injectables for obesity, which are obviously in the news every day at the moment. But also early immunotherapies for cancer and disease-modifying treatments for inflammatory disease and mental health are most effective when that disease burden is low. So it is all about early detection, enabling those interventions to be most effective. So how will our future health help drive this change? So we are, as you all know, going to be a cohort. We aren't quite yet, but we're going to be a cohort of 5 million volunteers sharing information of multiple different types, which we'll go into in a second, to create a detailed picture that represents the whole of the UK and represents also the diversity of the UK. And as a platform, we will enable studies of many different types that focus on new approaches to prevention, early detection, and treatment. So we're hoping to enable, as I mentioned, research around kind of these 4 areas, particularly also bullet point number 4, ensuring that our research, we've recruited an incredibly diverse cohort, and we need to ensure that research also benefits the broad diversity of the UK and worldwide. I'll just take you through how the program works for those who aren't familiar. So participants are invited to join and receive a sign-up letter and can register on our portal, enter their details, and complete a questionnaire. And the baseline questionnaire is incredibly important because it gives us a good sense of a number of factors across different types of health and lifestyle data, which are really important for researchers in the future. And then there is consent, and there is a blood sample is also taken at a clinic appointment. The 2 blood samples are sent to our labs for genotyping. And then we also take some physical measurements, and these are baseline physical measurements such as height, weight, and blood pressure. So we have 2.4 million people already taking part, which is an incredible achievement. This has been over the last really 2 to 3 years. The rate of participation has been astounding, and it really speaks to the excitement in the UK to take part in something that will help improve the NHS and improve the way we deliver care in the future. In particular, our resource, what's also really exciting is our resource reflects the diversity of the populations in England, Wales, Scotland, and Northern Ireland by age, sex, ethnicity, and deprivation. And we can speak more to that in the Q&A if needed. But one of the things that's really important about that is that most of these cohort studies in the past, particularly ones holding genetic data, have really only indexed along kind of white male populations. And so this is essential for enabling research into conditions that affect people of different backgrounds. So where are we heading? Well, the next phase of our future health, we continue to recruit to reach that 5 million target. But the next phase of our Future Health is to open up for further opportunities for our participants to take part in research that will improve the health of the nation and beyond. And what does that look like? Well, one of the exciting things about our scale is that it enables, for example, studies into rare disease or underrepresented communities, but it also enables studies into prevention and detection studies, because we can recruit enough people to basically observe the emergence of those conditions over time. So the 4 ways in which participants will be able to further engage with the cohort, the program, and our partners is through these, which I'll just go through now. I'm running out of time, so I'm going to speed through this and we'll do more questions afterwards. So we're going to start offering population level health insights. We've started already through some of our outreach to participants. That's intended both to continue, communicating how individual contributions are connecting to the cohort and to our research aims and research impact. But also we will be working with government bodies to help leverage our data to help them understand and shape policy and planning and better understand the health of the nation and where resources need to be invested. Examples of those are here. So really kind of questionnaire-derived sleep insights, for example, at a population level, blood pressure statistics by age and ethnicity. The second area for engagement is we are going to start offering individual level health insights. So we already do with measurements taken at the appointment. Those will soon be available digitally, but also health questionnaire insights and established disease risk scores where there is already disease risk scores available. We'll be offering those based on our data to our participants. And finally, health feedback. So we call this slightly different to health insights, but this is where we will be able to offer our participants access to genetic risk of disease as part of additional research studies. So one way that we are hoping to catalyze research into detection prevention is through offering our participants the chance to take part in additional studies run by additional partners. So that might be, for example, a clinical trial into a new way to prevent disease. It might be a service evaluation into a new way to predict disease and how that prediction might lead into a care pathway. So this is a really exciting opportunity and creates a new way for our participants to take part and engage with the research. So in summary, we have a number of ways in which we're hoping to impact and change the model of care around prediction, prevention, and treatment. Continuing to build on our active baseline cohort of participants, which enable data studies like the one mentioned at the beginning. Enabling participants to take part in recontext studies for new ways of detecting and preventing disease, offering population health insights to health planners, and also offering individual health feedback to our participants for direct health improvement.
Nicola is Chief Executive of the Association of Medical Research Charities. She's a member of the UK Health Data Research Alliance Executive Committee, of the UK Biobank Board, and of the Genomics England Board. Nicola was founder of Understanding Patient Data and former head of policy at Wellcome. So she's a busy woman, and this is an area I feel is, that's her home turf. So I'm very much looking forward to hearing her presentation.
I was involved in the very early days of Our Future Health, long before it was Our Future Health, even before it was, I think it was ADD, and before that it was some combination of E's and D's and R's and P's for early detection and diagnosis. I was involved in the early stages of helping to develop the ethics and governance framework, in which we had a lot of conversations about feedback and follow-on. And I have to say, from those very early conversations, way before there was a name or a brand, it's absolutely phenomenal to see Our Future Health already having 2.5 million people. So it's been an exciting journey to watch. I'm just very quickly going to say a bit with my AMRC hat on. The screen at the moment shows the logos of all our members. We're the umbrella body for more than 150 medical research charities ranging from the very large household names, British Heart Foundation, Cancer Research UK, Wellcome, through to a tail of much smaller charities that focus on a single unmet medical need, rare disease, or genetic condition. Together, they fund about £1.6 billion of investment in research in the UK every year, and we'll be publishing the latest stats for the sector tomorrow, so do watch out for those. Hopefully you will all recognise some of the logos on your screen at the moment. Hopefully you may even have donated to some of them or even run a marathon for them. So it's an amazing sector that I'm lucky enough to represent, but also it's a sector that is extremely interested in our future health, and it's really important to them. We have 4 funding partner charities, so Asthma and Lung UK, British Heart Foundation, and Cancer Research UK are funder partners for our future health, and then 20 charities are affiliates as well. What does that mean? It means that they all see the value of the resource for the research that they fund and for the conditions that they are doing everything they can to tackle and to prevent. And they are also cheerleaders for it. Ever since they signed up, they've been doing what they can to encourage their communities to take part and to really help build the trustworthiness of the Our Future Health brand. Just to talk a bit about why it's so important for our charities, and I'll go through a couple of examples very quickly, starting with British Heart Foundation. So as I'm sure you will all be very familiar, your ethnic background affects your risk of heart and circulatory diseases. British Heart Foundation has funded a huge amount of research over the years that has shown that Black Africans in the UK are at higher risk of developing high blood pressure than white Europeans. Similarly, South Asians have a much higher rate of coronary heart disease. But they really now want to understand more about why that's the case. And the scale of the data in Our Future Health will really help them to do that and to understand more about genetic predisposition. Moving around the screen, and these examples follow very neatly the sort of examples that Cosima was talking about. So Cancer Research UK is obviously really keen to improve early detection because that makes such a massive difference in survival. And the resource will really help them identify those subgroups that might be at high risk and invite them to take part in follow-up studies to find new ways to prevent onset. Cosima talked a lot about the health insights and feedback. That's already happening with a predictor tool that Diabetes UK has developed, the Know Your Risk tool, which some of you on this call might have tried yourself. You answer a number of questions about your health, your physical measurements, your family background, and it calculates your risk of developing type 2 diabetes in the next 10 years. People who are taking part in Our Future Health, the measurements that they get in that initial appointment, they can feed into the calculator, and then the advice is if they're going to be high or very high risk, they're advised to go and see their GP and to get advice on diet, activity, medication, monitoring. And there's already lots of people who have done that. The data from volunteers within the cohort will then be used to keep refining and improving the calculator so that it will be as efficient and evidence-based as possible. And then a final example, moving on to Asthma and Lung UK as one of the other founding partners. Respiratory conditions, one of the biggest challenges for respiratory research, surprisingly, is recruiting enough patients onto the studies. There are just too many examples recently where trials have had to close because there aren't enough people to take part who were willing to take part in trials. So what Asthma and Lung UK are hoping is that Our Future Health will be a really useful cohort of people that can be invited to take part in trials and to be contacted. But also you can use it to identify and target subgroups that would be particularly appropriate to use more research on. So, for example, there is a very small population of people who are smokers that don't get COPD, chronic obstructive pulmonary disease. If you could drill down into more detail about that subgroup and understand more about them, you may be able to find out new ways to prevent COPD among smokers. And so they're really keen to be able to identify subgroups and recontact them through the cohort. So that kind of hopefully gives you a bit of an idea of why feedback and follow-up that is possible with our future health is so important and offers huge potential to our members. But that obviously doesn't mean that it doesn't come with challenges. And I think the approach to giving feedback and recontact is one of the huge differences between our future health and some of the previous cohorts, particularly ones like UK Biobank. At first glance, I think you would think giving feedback is now the obvious thing to do. The situation has changed a lot over the last 20 years. It's a way of keeping people engaged. It gives them something back in return for their contribution, and it's useful information about their health. But in practice, it becomes much more complicated than that. And we really discovered that in detail when we were developing the ethics and governance framework. I'm delighted that Mike Parker is here today because he can talk you through the complexities of those ethical issues in much greater detail than I would be able to. So I'm not going to even attempt to do that. But what I will do is give you a couple of just very high level reflections. First of all, about the impact on participants, and then the impacts for the NHS and wider system. So first of all, for participants, I think this piece about managing expectations is absolutely key. And I was really struck by one of the comments from the Ethics Advisory Group that was made in the very early stages of discussing the ethics framework. And what they said was, potentially, when you're asked to sign up to our future health, you consent sounds a great project. Yes, you want to be part of it, but you just don't, it sounds like it's the right thing to do, but you don't really think at that stage about what the long-term implications of that might be. And you absolutely don't realize that potentially this could be a really significant life-changing decision, because the information that you would get as a result of feedback could be life-changing. You might find out that you're at very high risk of developing dementia, for example, which you otherwise wouldn't have known. Clearly, our future health is not just going to land that information on you. It's going to be done in a very careful way. It's going to be managed. You'll have choices along the way as to how that information might be given to you. But I think it's really important to be aware of those managing expectations right from the outset, while not being overwhelming as well, because this might not even be something that you're asked if you'd like to find out about. So looking at the latest version of the participant information sheet, I think the team have actually done a really good job of setting the tone right. I know it took a lot of iterations to get there, but I think the information is good. I think it's also really important to remember that the importance of this being an ongoing conversation, because whether or not people will remember that little paragraph that's on the screen now that they signed up to right at the beginning, will they remember that in 20 years' time? Who knows? So managing expectations is really important. The other bit is the expectations about whether this is a research cohort as it's billed in all the participant information and the consent form, or how does it fit on the research care spectrum. So it's a very, very clunky spectrum that I've put on the screen, but it sort of shows you that Biobank is absolutely down the research end, no question of feedback. You're taking part for altruistic reasons, you don't get anything back. Genomics England initially started much more from the clinical side. 100k genomes people were looking for a diagnosis, which is why they joined up. They then become part of a research program. I think our future health is in a very different place from either of those, right in the middle, where as you begin to give feedback, it potentially becomes much more blurred as to whether this is research or clinical care. Do they think the information they're being given about risk is that medical advice? If you're then asked to take part in a trial and you get clinical treatment, where does that leave you on the spectrum? So again, I think those kind of expectations are something that it's really important for our future health to think very carefully about. And then secondly, at a much bigger picture level, to go from the individual volunteer through to the whole system that our future health is working in, the impact on the NHS and the wider system. We've talked already a lot about the importance of prevention. You will all have heard the 10-year health plan shift from treatment to prevention and just how essential it is to do things differently if the NHS is going to be fit for the future. And there's a real opportunity, as Cosima was saying, that our future health can help make that shift possible and help to do it better. But that means improving the ways we understand risk, the ways we understand prevention, and the ways we provide feedback. And I think you see that already with polygenic risk scores. There is still a huge number of question marks about the evidence base underlying polygenic risk scores, their clinical validity and utility, and concerns as well about diversity. A lot of the scores have been based on the genomes that we already have analysed. That doesn't necessarily represent a diverse population. And so it's going to be really important not to exacerbate those inherent biases in the data and in health inequalities by relying too heavily on polygenic risk scores too quickly. But I think our future health has a real potential to help improve and refine the models and make sure that if they're going to be used in the clinic, they can be used in a safe, effective, and equitable way. I think the other thing that we can think of with our future health is learning much more about how to provide risk information and feedback. And you can understand more about how patients and healthy people respond when they're given information about their risks. You can look at what kind of support is needed and how to provide the information really sensitively and appropriately. And so I think there's a real role for our future health in developing a model for giving that feedback, what it needs to look like, who should provide it, what support's needed, but also what the resource implications for the NHS. And I think that's going to be a big feature of the discussion, both the implications if 5 million participants in the Our Future Health cohort all go to their healthcare professionals with their health advice at the same time, but also taking that from a small scale to how you roll this out across the population as a whole. So I think there's a real role to think about the implications for the NHS, both now and in the longer term. So coming back to the kind of longer term impacts of our future health, I think there is, as you've heard already, and you will keep hearing this evening, huge potential. I think one of the most exciting things is the opportunity for our future health to really set the gold standard and best practice in how a cohort of this size provides feedback and how it does it really well and thoughtfully in a way that then can change the way we deliver healthcare.
So following on now from Nicola, we have our next panelist, Professor Mike Parker. And Mike is director of the Ethox Centre and the Global Health Biobanks Network. He's a professor of bioethics at the University of Oxford and is chair of the Ethics Advisory Board of Our Future Health. Mike is also the author of the book Ethical Problems and Genetic Practice, among many other things. That's a very short list of his committees, I have to say.
I'm currently the chair of the Ethics Advisory Board for Our Future Health for about a month longer. Been doing it for a while now, but I'm obviously not speaking from that position. I'm essentially just sort of saying a few thoughts that I have, but also drawing on some other experience. I'm also currently an ethics advisor to UK Biobank, and was until fairly recently on the board of Genomics England, so sort of pulling on those different things. And Nicola, despite what you said, you did a fantastic ethics talk there. So you've said lots of things which I can build on really nicely. So thanks very much for that. The other thing I wanted to say is that Our Future Health, in addition to having an ethics advisory board, has an in-house ethics team, which is an absolutely fantastic resource. So these are people who are part of the Our Future Health organisation, but are there to respond and address and help Our Future Health think through ethical questions. And I think that's an interesting, great innovation, and actually it's a fantastic group of people. So I just want to give them a shout out that I'm not doing all the ethics here for Our Future Health. I guess so. My starting point often when people think about ethics is they think about regulation, governance, ethics committees, or kind of scandals. And they're all important, of course, but my starting point generally in this kind of situation is to think that scientific progress, particularly when it relates to people's health, matters morally, in addition to the whole range of other ways in which it matters. So, and the key thing for me in this kind of role really is to try to think, in addition to scientific, technological, economic, other issues which are relevant to the success of something like Our Future Health, there are a number of, as we've already heard, a number of important ethical questions that need to be identified, thought through, and addressed in ways that are going to make the initiative successful but also conducive to public trust and confidence and the confidence of those who have participated in it. So that's kind of the angle that I'm coming from. And I guess in relation to that, one of the important questions I think is worth reflecting on. So this is what I'm going to do today, I guess, raise some questions to think about rather than answer any of them. I think an important question is to think about what's the relationship between a feedback policy and an approach to feedback and the success and trustworthiness of the science in not just our future health, but more broadly. And it seems to me there is a relationship. There are a number of relationships, and it's worth thinking about that. So there are some very specific issues to do with feedback in particular people, participants, but there's also a bigger issue. I think this policy plays into that. So one of my most abiding memories of being involved in Genomics England, for example, was meeting regularly with the participant panel and them being the thing they were most unhappy about was things to do with delays to them hearing about the progress of the science, what was happening with their samples and so on. So, feedback, I think, from that perspective, made a huge difference to them. Not only feedback about their health, as it were, but feedback about what was happening. So I think these things are really important. And it's also important, I think, from an ethics perspective, to disaggregate some of the kinds of feedback we're talking about. So, primarily we've been talking thus far about the kinds of feedback that may be clinically relevant, to one degree or another of certainty and importance and seriousness. So that's one cluster of sets of feedback which raise a whole range of ethical questions that we've just talked about. But there are also a range of ways in which people can find out things about themselves that we've also heard about. So being recruited for a trial, for example, the way in which that's done and the kind of information one receives at the point of invitation or further down the line, in this kind of context, is likely at some point to reveal something about your health. So that's another kind of way in which feedback can happen. I think, and as I just mentioned, I think a really important kind of feedback, which is often underplayed, is just general feedback about what's, the progress of our future health, what's happening, what kind of things are being found out. So it's really nice, for example, that you shared that paper in the link. But I think, just expecting participants to look at publications or wait for news stories isn't enough. I think actually there's a really important obligation to really keep people up to date, with how the initiative is going, particularly if you want them then to subsequently to sign up to studies. So I think that's often undervalued kind of feedback. And then the fourth kind of feedback is something, I'm not sure what to call this, but sort of the idea that we might think about feedback models in a kind of experimental way. So we might think, well, okay, let's try some different kinds of feedback, of kinds of information, and polygenic risk scores of one kind or another might be a form of that. And let's innovate in the space and do it in a careful way and learn from, what's useful, what people want, what they don't want, and so on. So I would want to include a sort of experimental feedback kind of opportunity there, and that set may end up being empty, but it may be that there are things that could be done there, and inevitably that would raise interesting ethical questions too, I think. After that, I wanted to sort of pick up on Nicola's point about the kinds of changes in the expectations that people have that have happened over the time since UK Biobank was started and Our Future Health was. So as Nicola said, UK Biobank at that time, it was pretty common practice and perfectly acceptable to say we're a research study, we don't do feedback. Our aim is to put all of our effort and intention into generating science and understanding disease and so on. And that was a reasonable thing to do. Times have changed slightly, so I think that's less likely to be acceptable now. That's an interesting question. There may still be a place for that kind of study actually, but then you've got Genomics England, which is very much clearly on the interface between health and research. So you've got a study which is set up from the participants' point of view to help them, in many cases, to get feedback about the developmental disorders, for example, that their children are faced with, or maybe to do with their cancer. So this is something which is explicitly feedback is built, at least to that degree. And there are other kinds of feedback that might be available too, which you can say more about. And then Our Future Health, as Nicola says, sort of sits in between those two things. It's essentially a research study, but it's trying to do some feedback too. So I think this is a really interesting space. So there are two things there. One way of thinking about this is times have changed and not giving feedback is no longer acceptable. There's another way of thinking about it, which is that there are a range of different available models that all might be acceptable under certain conditions, but might generate different responsibilities depending on which model you choose. So that's an interesting kind of question too. I think there's another way in which the world has changed around this, and that's the increasing closeness between research and practice. We're talking here about our future health, but if I'm sort of imagining the future beyond our future health, it seems to me highly likely and potentially desirable that you end up with an NHS in which clinical practice and research are fully integrated with one another, and we have a learning health system at a national scale, and that seems to me something we potentially might want to see happen. But that bringing together of research and clinical practice raises a whole range of interesting kinds of responsibilities potentially. So we need to think about that. So we've got the changing expectations, we've got the changing relationship between health and research. We've also got scale. So when our future health is completed, there'll be other people from other countries too, but it'll be essentially 10% of the English population. That's the kind of scale we're talking about here. So do our obligations change once something gets really big? And I think that's an interesting question, because it strikes me that people may start to think about these initiatives in a different kind of way, the bigger they get and the closer they get to the health service. And I think that might be an interesting thing to think about. And then the final thing that's changed, I think, is that certainly in the UK, and I'm sure it's true in the US too, our future health is a really important national initiative. This is, to a significant extent, funded by UK taxpayers' money. To what extent might there be expectations and responsibilities at a kind of national level, because it's a national project? And I think that's something we perhaps haven't thought about as much as we might have done. I think I've got about 5 minutes left, have I? Is that right? I think 4 or 5. Yeah. Okay, so I think one of the ways of thinking about ethics here at that high level is the landscape has changed in ways which generate new and interesting responsibilities, and they're not just clearly things we can take off the shelf. There's a need to think carefully about that landscape and to think about, well, what kind of responsibilities is it reasonable for us to think that someone working in our future health, someone designing it, ought to have to the participants and to the wider world. So that's something I'd be interested to come back to. Then I think another kind of really important question is to do with this concept that Nicola used, which was the idea of reasonable expectations. It seems really important that at the beginning of this process, when people are recruited, that they're in a position, and I guess the scientists, the studies in a position to have a sense of what it's reasonable to expect. So there's a kind of social contract, as it were, between the participants, the study, and potentially the health system too, about what it's reasonable to expect. And that places, I think, an important weight on the consent process. And as Nicola said again, this needs to be done well at the initial point, but it needs to be something that's kept alive, because it's important to remember that a consent form is not a contract. So it's tempting to say later on in the process, when a researcher wants to use the data for something, oh, well, it must be okay because it was mentioned in the consent form and the participant consented. That's not how consent works. I mean, there's a sense in which it works like that, but there's also a sense in which it's about keeping people on board and maintaining public trust and confidence in the longer term. So I think it's really important that we remember that consent is something that needs to be thought about actively. And there are obligations there to be clear, to be understandable, to do a really good job. And there are important, interesting questions then about the fact that much of the work that's going to be done on the data and as generated by the platform Our Future Health is going to be not knowable at this point. So there's a degree of open-endedness and uncertainty in that process. So that suggests that any consent process, no matter how good it is never going to be specific. We're not going to be able to say, these kinds of things are going to be done on your data in any specific way. So consent is going to have to be reasonably broad, and I think that's perfectly fine. And that's a perfectly ethical way of doing consent. We do that, in our everyday lives more generally. Think about getting married, for example. So there are a whole range of ways in which we can't know exactly what's going to happen, but the consent nonetheless is valid. But I think what this does suggest is that consent is not enough. So we tend, I think, sometimes in research ethics to think that if we've got really, really good consent, then essentially we've got everything in place that is needed for research to be ethical. And I don't think that's the case. So I think one of the questions that Our Future Health and these initiatives need to ask themselves is, let's assume the consent is done really, really well. And let's assume that people have as good an understanding as we might reasonably expect of them. What other things need to be put in place to ensure that those people are going to be not going to be harmed, that they're going to have a sense that the kind of things that are being done are at least compatible with the kind of things they might reasonably expect? And it seems to me that that raises all sorts of questions about what our future health should be doing beyond consent, as it were. And I think this then relates to questions to do with trustworthiness and confidence, which we can perhaps come back to in the conversation. Then the final thing I wanted to say was just, I think an important ethical question is, I think the biggest ethical question in genetics, I've always thought this, is resources. So let's assume that we think it's really important to give some feedback to people. I think a really important question is, what's the opportunity cost that raises? So I've said it provides all sorts of benefits, but how much resource, how much time, how much money, how much effort should be put into giving feedback? It strikes me some should be put into it, but there's an interesting question about how much, because this is effort that could potentially be put into research and other things. So, and I don't think we've actually ever answered that question if done resources in genetics in the context of a public health system as much or as in depth as we ought to do, really. So there's a high level skim over some issues, prefigured in great ways by Nicola, and I'll stop there.
Our final speaker is joining us from the USA, and it gives me great pleasure to introduce Dr. Geoff Ginsburg, who is Chief Medical and Scientific Officer at the All of Us program at the USA's NIH National Institutes of Health. Previously, he founded and led organizations including the Center for Applied Genomics and Precision Medicine at Duke University, where he remains an adjunct professor. He was at the Global Genomic Medicine Collaborative and the International Health Cohorts Consortium. Geoff is a co-editor of the book series Genomic and Precision Medicine, including volumes on foundations, translation and implementation, primary care, cardiovascular disease, and also oncology.
So today I want to tell you a little bit about the All of Us research program. I think you'll see some parallels with our future health, even though the scale is a little bit different. And then I want to share with you some details about our efforts to return genetic results to our adult participants in the All of Us research program. So on the next slide, maybe for a moment, I'd like to reflect on the value of cohort studies. And some of you may know that in 1948, in a small town in the state of Massachusetts here in the United States called Framingham, a study was begun in about 5,000 individuals, men and women, who were going to be followed for some time. They actually are still being followed today, as well as their children and their children's children. But importantly, in 1961, a paper was published coming from the Framingham study, which defined the risk factors for cardiovascular disease for the first time in the history of medicine. And I would argue that that paper was one of the most transformative in medicine to date. And this slide shows the impact of the implementation of risk factor modulation and modification on, at least in the United States, on the incidence of and the death rates from cardiovascular disease, coronary heart disease, and stroke. And you can see over the last several decades, there's been a precipitous drop as these have been more used by health professionals as well as integrated into electronic health records. So it's not, next slide, please. It would, if that could be done in 5,000 people in a period of 13 years, imagine what could be done with 1 million people followed over time, or 5 million people over time. And that's really the impetus for the All of Us research program. We view this as a platform for research for the United States, but for researchers worldwide, that will accelerate discoveries and increase innovation and efficiency in research, and hopefully ultimately not only reduce the cost of research, but reduce the cost of clinical care. And we have been able to achieve what I'm going to show you through partnerships with our participants. And those, it's been mentioned before, but we view our participants as partners in our research program. We've committed to them to return value, and in this case, in the form, at least today, of returning genetic results, but there's other value that we provide to them that we can discuss in the conversation. And we also have made an effort to be completely transparent about how we're carrying out our program in an effort to build trust with our participants and to keep them engaged with the long-term prospects of a program like this. And in doing so, they've donated data to create one of the largest biomedical research databases in the world, which acts as a catalyst for researchers across many communities. We now have over 17,000 researchers using the All of Us data. So, and I'll tell you more about that in a moment. On the next slide is our progress to date. Well, actually, this slide shows the process by which our participants go through in delivering data and how that data is delivered to researchers. So on the left-hand side, you can see that we've now enrolled 860,000 or more participants who've donated biospecimens and electronic health records and significant amount of survey data information that you can see on the left-hand panel. Those data are curated in a centralized data repository and hosted on a cloud-based platform that is now accessible to researchers. And this slide is a little dated because I did say 17,000. We're above 17,000 registered researchers from over 1,000 organizations around the world and a growing list of publications. And importantly, and we'll talk about this in a few moments, we've delivered individual DNA results to more than 200,000 individuals. And the positive rate of having a finding that could be actionable has been 3% for disease-related genetic variants and nearly 100% for pharmacogenetic related variants. And I'll talk about that in a little bit more detail in a moment. On the next slide, this is the data I've just shown you. The participants that have consented, over 800,000, those that have donated electronic health records, and the ones that have contributed survey information is on the left. On the right-hand side is a 3-digit zip representation of the density of participants across the states, the 50 states of the United States. And you can see there are some significant hotspots in the southwestern United States, in the north midsection, as well as in the south. What's important here also to recognize is that not only do we have geographic distribution that you see here, but distribution in terms of race and ethnicity. And we've made a significant commitment to enrolling individuals who have never been offered the chance to be in a biomedical research program. And we categorize those individuals on the basis of their race and ethnicity, their extremes of age, their educational levels. Lower educational levels often aren't part of biomedical research studies, individuals with disabilities, and individuals from rural or more rural areas of the United States that generally are not accessible to academic and tertiary care medical centers where a lot of research is conducted. The next slide. This slide will highlight the amount of data that we've not only curated, but released to researchers over the last several years and what we forecast to release sometime in the first half of 2026. So as you can see, that we have survey responses currently in the dark blue bars. That was the release in February of 2025 of over 630,000, as well as physical measurements on over 500,000. Genotyping arrays, as well as whole genome sequences in the 400,000 range, and electronic health records close to 400,000 as well. And you can see that those numbers will increase by 20 to 30% when we release our data set to researchers in 2026. And on the right-hand side are some smaller data sets, but important ones. Exploring the Mind is a series of cognitive function tests. We have an enormous amount of wearable technology data that gives us real-world continuous phenotypes and features of individuals as they traverse their daily lives. And one of the largest long-read genome sequence data sets ever released to researchers is currently available and will be augmented next year. And in the box, you can see we have plans for other types of data through our multi-omics projects, linkages to claims and mortality data, and other types of studies that probably time will not allow me to go into in great detail today. So if you go to the next slide, I mentioned that we're returning results to our participants. And what you see are the 4 types of genetic results that we plan to release and that we have released. So in the top bar are genetic ancestry and traits. And in 2020, we began offering these results, and the data shows that in all the cases I'm going to talk to you about 50% of our participants have said, yes, we would like to receive this information. So nearly 220,000 individuals learned about their genetic ancestry as defined genetically, and the regions of the globe from which what their genomes are telling us about their origins. And then maybe just for fun, we had a number of non-health related traits that you can see on the right-hand box, that people learned about their ability to produce earwax, whether they had bitter taste, whether they did or did not like cilantro, and whether they were lactose intolerant. But the more important health-related information is in the middle and the lower panel. We developed what we call a hereditary disease risk report that reports on 59 genes that have been determined by the American College of Medical Genetics and Genomics to be reportable as secondary findings after a genome is sequenced, because they're actionable and potentially could lead to changes in health management or health care. And you can see on the right-hand side, I mentioned this before, about 3% of our participants have a finding that could influence their health. That's nearly 4,000 people to date, and that number will continue to grow. On the bottom is our pharmacogenetics report, the report on 7 genes that could influence the top 50 prescribed medications in the US. Nearly 120,000 people have received this report, and greater than 90% have had a positive finding, which means that many of us in this call, in this conference, will have pharmacogenetic findings that could influence a medication that we might be on sometime now or sometime in the future. So the types of genes, for example, that are reported for disease risk have to do with things like BRCA1 and 2. Those are our highest frequency positives. These are genes associated with hereditary breast and ovarian cancer, Lynch syndrome, genes that are associated with endometrial and colon cancer, and as well as genes associated with hypercholesterolemia and the risk of heart disease. On the next slide is the pharmacogenetics analysis, just to highlight the fact that there are some really striking frequencies of positivity in the population. I know some of these terminology may not be familiar to you, but the CA-CNA1S and the RYR1 genes are genes that, if you have a genetic variant and you receive general anesthesia, you're at higher risk for a condition called malignant hyperthermia, which could lead to death in the operating room. And there are other genes associated with the metabolism of drugs associated with commonly used cancer chemotherapies and commonly used heart disease medications. And our analysis shows that nearly 30% of individuals currently in our program have a genetic variant that is influencing a drug that they're currently on, which means that that drug may not be as effective as it could be, or worse, they could have a side effect potentially that could be detrimental to their health. So that's why we're reporting these results. The next slide, just to highlight the fact that we made a major switch in the way we're delivering genetic testing to our participants a couple of months ago. Up until April of 2025, when we sequenced a person's genome and they agreed that they wanted to learn something about their genetic results, we sent them to another provider called Color Health for a confirmatory test in a clinical lab, and that result was delivered with genetic counseling to that participant. We decided to switch directly to offering individuals genetic testing in a clinical lab with Color Health in April 2025, and not to base it on our research genomes that were being sequenced, that we're continuing to sequence. That's been a major shift, but it's gone very smoothly and continues to go well. On the next slide, I think a question we all have is, what's the impact of return of results to individuals and to populations? So we've developed a research agenda that we're hoping to launch later this year on the 200,000 plus individuals that I've just talked about, to learn how they've understood the results, whether they're motivated to share the results with family members, with healthcare providers. Does it change any of their personal health decisions? Can we learn if their healthcare provider actually understood the meaning of these results and changed the management for those individuals? And did they receive follow-up testing and evaluation that led to a preventative therapy or diagnosis? And how does this impact overall healthcare utilization? Is it net positive or net negative in terms of the cost to the healthcare healthcare delivery systems. And that relates to the question of clinical utility. Does it provide a change in outcomes or personal utility, which means outside of the healthcare system, have I done something for me personally that would impact that these results has impact where these results have impacted my lifestyle or how I interact with my family members. So the next slide, and I'm almost done, is kind of some of the lessons learned that I thought might be useful to this audience as you all consider this large-scale return of results. And our website made it clear that results were only going to be provided if the participant opted in. So the opt-in process was really important for trust and engagement of participants. And in our system, to be cautious and conservative, we engaged with the Food and Drug Administration in 2015 or 16 at a time when whole genome sequencing derived results was really not very common. And this led to the FDA requiring us to have something called an investigational device exemption, which put a lot of controls over the way that we could manage data and interact with our participants. So in essence, this was in some ways a blocker that we were able to overcome, but there were significant challenges. We built a scalable process and accessible platform. And most participants pursued the free clinical confirmation that we offered them, the genetic counseling, which I think I mentioned is both in English and in Spanish. And some of our participants declined because they actually knew some of these results. They had consumer genetic testing or they didn't think it was valuable. We also have had participant ambassadors throughout the course of our program continue to do so. They provide feedback on process improvements, improvement in communication, improvement in the way that we deliver results and report them. And then finally, and probably interestingly, the DNA results were not only returned equitably, but there were very few differences in the request for return of results across the highly diverse and populations and unrepresented participants that we had in this national cohort. So finally, on my final slide, more to instigate interest in using our research data. There's a very streamlined process for researchers in the audience to sign up, work with your institution to get access. It's a passport model. Anybody in the institution, once it's approved, can access our data. And then within 24 to 36 hours, you'll be working with data and be able to contribute to the science that we're hoping will change individual and population health.
Now, before I go, we've got quite a few questions, but just before that, would like to give the panel the opportunity if there's anything arising from each other's presentations that you would like to ask one another. So now's your opportunity to ask each other, but if you're all looking quite reticent, so I shall go to the most popular question that we have, which is for Cosima, which is says, we know that for most people, lifestyle will have a greater effect on future health than background genetics. Wouldn't a focus on stopping smoking, reducing alcohol intake, addressing obesity, and improving diet and exercise have more effect on population health than genomics? If the amount of money being spent on our future health was spent on public health, wouldn't the benefits be greater? So there you go.
Well, I'm sure that many others on this call have thoughts on that as well. So maybe I'll start, and then if anyone else has any thoughts they'd like to contribute. It's a great question, and absolutely, we need to continue to invest in improving diet, addressing obesity, reducing alcohol intake, and stopping smoking. But I think, as perhaps has really nicely highlighted by Geoffrey's Ginsburg's mentioning of the Framingham Heart Study, is that there are many conditions for which we do not understand what prevents it, and we do not understand how to detect it early. And so I think in response to your question there, our future health is aimed at both broadening that scope. What is the Framingham Heart Study of the future for Parkinson's disease, for example? And obviously there are we do know that there is potentially a metabolic aspect to Parkinson's disease, but there are other causes that we don't understand. Second, our future health, we are a research program, and we are not an organization to deliver on direct public health interventions. We're going to be offering health feedback. It may improve people's outcomes, but just like all of us, our goal is to enable the evaluation of new risk information, be that genetic or non-genetic, and how that can influence both behavior change and also what are the different care pathways that are needed within the NHS to support that earlier detection and earlier prevention. I don't know if anyone else would like to come in to add anything to that.
Geoff, do you want to come in? And then I might go to Mike because it comes to his ethical question of resources. So, Geoff.
Sure. Well, first, I also agree it's a good question. And certainly, public health initiatives in both the US and the UK have been very aggressive in reducing smoking campaigns and diet and exercise. But I would argue that prevention is not one size fits all. And I'm sure Mike might comment on this, but we don't have enough resources to really blanket the entire population with everything that's needed to influence their behavior. So one way to think about it is that the genetics and the risk scores that are being developed, as well as other risk algorithms, will allow us to understand who we should target those interventions to and be more effective in the utilization of resources. So I think that's one aspect that the genetic information might allow us to understand. And then the other thing I'll mention is I don't think that behavior is one size fits all. The way that individuals respond to understanding they're at risk is going to be influenced by their culture, their understanding, social determinants of health, the environments that they're in. So we have to recognize that just because we provide information about prevention, that not everybody's going to respond the same way. So we need to understand that aspect better to make it more individualized.
And Mike, did you want to come in on the sort of resource element here?
Well, I mean, firstly, I think I agree with the others. This is a really important question. I think it's the kind of question that we need to be asking ourselves. But so, clearly, I think we all agree that efforts need to be put into impacting, in addressing behaviors and other things that impact health in a major way, like, as you say, smoking, obesity, social deprivation, and so on. So clearly, resources need to be put there. Resources also need to be put into the kinds of things that I think it was that John said, that we all know, and it's what, that being able to intervene earlier in cancer, for example, makes a huge difference. So you wouldn't want no resources to be going into that. You clearly will want some effort to go into that. And then thirdly, we all know that scientific knowledge and generation, is vitally important. So, I don't think there's an either or here. But there is a really important question about how much money we put into, thinking about rather than what our future health does as a nation and internationally, how much resource do we put into addressing well-known health problems, addressing problems that we're kind of aware of and we need to understand better, and doing science. And I don't think there's a simple answer to that question. And there are opportunity costs all around, and that's like essentially a democratic, kind of process, I think, political process.
And Nicola, I think you wanted to come in.
Yeah, Mike then said exactly what I was going to say about it not being either or. You need research and public health funding. But if you don't fund the research, we'll only be providing the public health interventions on the basis of the knowledge and understanding that we have now. And if you look at the Framingham example, we know now what we didn't know then. So you have to have the research to keep improving the public health money and to make sure it's spent as effectively as possible. I think the other thing that we don't yet have a good enough understanding about is multiple long-term conditions. And as Cosima started off with, people increasingly are living with not just one condition, but 2, 3, or 4, and mental health conditions as part of that as well. And so I think you do need the research to really be able to understand the connections and how you can intervene most effectively. And obviously, this isn't the only way of doing research either, but it's one of a sort of range of approaches.
Yes, and I guess it's sort of a bit like was sort of mentioned in the paper that was published today from Our Future Health. It's picking up on the psychological connection with inflammatory disease and thinking, well, actually, we can see this. Is there something we can be doing now for early intervention for which is part of public health, really, in avoiding these people having these mental health conditions down the track. So yeah, so I think it is it's all you can't really separate it out in some ways, I don't think. I don't know. Um, so I'm going to go on now to the next question, which was also for Cosima. This person says, but I think everyone's going to want to come in on this. There's a lot of hype around polygenic scores, and I understand they're useful on a population scale. However, there doesn't seem to be much evidence, at least so far, that they're usefully predictive for individuals. So what's your view on that?
Great question. Well, that is pretty much what we're trying to do. So when I mentioned polygenic risk scores, as mentioned before, as a research program, we are not necessarily rolling them out to everyone as part of standard of care. That's not what's happening at the moment. We are focusing on the research questions. So what is the clinical utility? What should the service be that wraps around the delivery of polygenic risk scores for different types of diseases? How will polygenic risk scores or not influence behavior change? And also particularly, I just kind of step back a second, because actually when we talk about polygenic risk scores, we are particularly focused actually on integrated risk scores, because in recognition of the fact that the genetic component for many diseases is a very small component, and actually it's the lifestyle aspects that are particularly significant. And so most of the scores that we will be working on incorporate genetic and non-genetic risk. So I hope that answers your question. Our goal is to establish some of that evidence, because we do recognise that it is not there yet.
And I could see Geoff nodding along there. Is that something you'd second, Geoff, or is things slightly different for you?
No. I completely agree with Cosima. And maybe just a couple of points is that Cosima mentioned clinical utility, but before clinical utility, you need something called clinical validity, which means does a polygenic risk score predict what it's meant to predict in various different subsets of the population? I think that's continues to be a significant challenge for the field, that these scores are discovered in a particular population with a particular ancestral background, and they may not be replicable or reproducible in another group. So that's one of the issues that I think the field faces. And I'm not sure I completely agree with the questioner that the utility at a population scale has been established. I think you need to be able to implement them into healthcare delivery to determine their real population health impact. And I just want to second again what Cosima said about polygenic risk scores combined with polysocial scores, combined with poly-environmental scores. The Framingham risk score is a multidimensional risk equation. I'm not sure that the discoverers of it were realizing that they really stepped on something really important, landed on something very important for the field of risk assessment, because it really encompasses many different dimensions of an individual, not just one. Genetics is only one dimension.
And I think, Nicola, did you want to come in, because you actually talked about polygenic risk scores and their utility and validity in your presentation?
Yeah, so I mean, I think we had really interesting conversations about this with the initial ethics and governance framework, and it's something that I know is continuing to evolve. But actually, the ethics advisory group was very cautious about a lot of this feedback and how to deliver it well, and particularly where, as you've heard, they're not clinically validated or of clinical utility, being really, really clear about that when the information is given. So almost separating out what's clinically validated when you're giving the information versus what you're giving that's still part of a research ongoing process, in which case the consent around that needs to look really different, and you're going back to the managing expectations, having a really different conversation about what this information is for. Using our future health to test it is going to be hugely, hugely important. So it's not a kind of, no, we're not ready for this, so we can't give them, because we're never going to be able to improve them if we can't do the research. And I think there is huge potential to use our future health to help improve them. But in order to do that, you will be using them with people, and so making sure that they understand what you can and can't say as a result of them. And it's really, really complicated. One of the I saw another question about this, talking about just how difficult it is to convey those messages clearly and accessibly is difficult. And that in itself is probably something that our future health needs to be trialing as part of this.
Yeah, so perhaps we'll move on to that question then from Michael Thomas, who says polygenic scores usually only predict small percentage difference in risk. Will feedback offer support to participants in how to make decisions based on small differences in risk? Now, I don't know, Cosima, whether you want to go first on that, or perhaps we'll go to Geoffrey. You know, if these are being fed back, how do you sort of manage to explain what is really quite new medical science, I suppose?
I think maybe Jeff, yeah, you answer that one
So
first
go
because
ahead.
we're
No,
still in the journey of learning that and developing that. So I'll leave it to you.
well, I feel like explaining risk to anybody is a very challenging concept. You know, I don't feel that that the medical community doesn't a very good job of conveying individual risk, and frankly, I don't feel like we should necessarily be offering individuals information um, on risk scores that only deliver an incremental change in what's already known about risk. So that's where the research agenda that we talked about in response to the last question becomes incredibly important. Does the provision of a polygenic score impact behavior? Does it impact downstream events in a way that is that proves that it's worth the investment to generate the risk score and to convey it to patients and participants in research studies. So um, I think we still have to learn from one another about how to answer this question, honestly.
Anybody else want to come in on that one? If not, I'll move on because we're quite conscious of time. We've got quite a lot of questions. So someone's said Mike Parker argued that feedback to participants in these sorts of projects should include feedback on how the project is going as a whole. Um, that's going to be made more difficult if the likes of Wes Streeting or future health ministers time announcements and leaks. In his case, an exclusive sneak peek at the imminent NHS report that he gave to a single newspaper to secure a favourable front page headline based on the world's what's most politically convenient to them. So there's a sort of tension there, isn't there, Mike, between the sort of funder and their political aspirations and having what you call in policy circles an announceable that's favourable.
Yeah.
How do we balance the ethics of all that?
I'm not sure it's that's about ethics. I mean, obviously there's an ethics about, doing things the right way and not undermining the message in lots of ways. I think that's absolutely right. I mean, I don't think they're incompatible. So the point I was making was that, I do a lot of my work is in low middle income countries, so this is a slightly different setting, but nonetheless, this was also true in Genomics England that people just didn't have a sense. They were bought into the project in the sense that they were committed to it, committed enough to participate, not personally, in some cases because they expected some health benefits, but not always. And were a bit frustrated about not, well, what's happening? What's happening? How's the science progressing? And that kind of thing. And I don't think it would necessarily require a huge amount of effort. Oh, clearly, there are resources involved to just keep people up to date in a way that made sense to them. So it could be, we found something and here's a paper, or it could be we've just installed a robot that is better able to manage the samples so that, we can do research more efficiently or something. So, clearly there's a need to manage that carefully, but I don't think that's incompatible. I don't think necessarily participants should get scoops, as it were. I don't think they should necessarily get first knowledge. I think they should just be kept up to date.
Nicola, did you want to come in on that? Perhaps Jeff's put his hand up first. I'll go to Jeff, and then I was going to that's Nicola from the sort of all the charities' points of view, really, with these things.
I just wanted to say that in the All of Us research program, we have regular communications both with our participants and our researchers through things like newsletters, of course, and we try to report the most recent scientific findings. They find our participants see that as an important return value. This is how my data contributed to advancing science. But then there's also another level. There are participants who want to know where their sample is. Like I gave my sample, so like, can you have a sample tracker that would tell me, is my sample, on its way to the Genome Center? Did it get processed? Did a sequence come out? All the kind of nitty-gritty stuff So there's definitely an echelon of or a subset of the participants that really would love to have views under the hood. And I have to just strike a balance because obviously we're all limited in terms of the resources that we can provide. But having the participant ambassador group tell us, more directly what they want to hear from us and what tempo has been incredibly invaluable.
Nicola, did you want to ask a minute?
Yeah, so I mean, you mentioned Charities' perspective on this. I think with news announcements, and it can be news stories about any research finding, not necessarily a cohort of this scale, it could be an individual trial. There's always that balance between hope and hype, and the headline is always the really exciting treatment that is going to change everything, and then there's the reality behind it. And often our charities do a lot of unpacking what the headline is versus what the reality is. And I think that's kind of what we were seeing in the announcement that I think the question relates to. There's the sort of the long-term 10-year vision of what could be possible versus where we are now. And I think that the key thing for the cohorts, and in this case it was Genomics England, is continuing a very evidence-based, careful approach to get from where we are now to where we potentially would like to be if all the evidence and evaluation along the way suggests it's the right thing to do. So it's not that we're there now, but how do we get there? What steps are needed? And the evidence base to make that possible.
Great. So I'm hearing, that what's really needed and really, really important is great comms. And even if the comms is like, oh, there isn't much news, but we're still here, we're still doing stuff. The boring news as well as the big headlines, isn't it? I think that they don't want to be forgotten about. And to know that they've not missed anything. I think there's always a fear of you've not been informed because you've somehow fallen off a list or something. Okay, so the next question is again addressed to Cosima in the first instance, but the person says research has shown that simply providing individuals with personal health data often fails to produce lasting changes in behaviour. How do you plan to address this challenge and explore ways to translate insights into sustained improvements in health and behaviour? And I guess this is one for Geoff as well to see what they've done. What is the impact of all of us?
Yes, absolutely. And I think that's very true for most of the risk score study to date. I think we don't have enough evidence on the contribution of genetic risk to that. We have a very extensive kind of public participant involvement engagement work stream, including our public advisory board and user testing. And so a big part of what our Future Health does, and we're doing currently, is testing different types of feedback and how that might influence behavior change. We're also going to be enabling others to conduct studies using feedback, because critically our cohort has consented not just to receive feedback, but also has consented to join recontact studies. And that's one of the areas where we also see a huge impact in terms of enabling prevention. Participants we can essentially recontact participants on the basis of some of this risk feedback and conduct studies into how that might impact behavior change. I think the other thing to say about this is that behavior change is one aspect, and one of the important aspects in the UK, at least, is determining what the care pathway is for early risk detection and disease prevention, because we haven't done it before. So, if you give someone their polygenic risk of, a condition like Parkinson's or motor neuron disease, there is no place to go to receive additional support. And so a really big part of this is what is the support that the health system needs to provide, and what kind of tests and what screening programs are going to be put in place. And so that's the other area where we're focusing. It's not just behavior change, it's very, very important. It's also about how the system supports people.
And Geoff, what systems do you have in place about supporting behavior change, and also, as Cosima said, the importance of support where there's not necessarily something you can do?
Yeah, I think to set expectations, one is that we should just recognize that we're at a really early stage of being able to answer that question. And I say I'm talking about the entire community. All of us is a research program. We're not directly connected to healthcare delivery systems where that behavior change might occur. But as we implement the agenda I mentioned about what happens to people after they receive information from the program, we have the luxury, I guess, of seeing people across a diversity of healthcare delivery systems and environments, and to learn in which of those environments is there more sustainable change than in others, and perhaps extract some of the best practices when we see that. So there's a large research agenda here that is just in the beginning stages of being implemented. Last thing I'll say is that remember that as people have volunteered to be in programs like this, that already means that in some ways they're biased. I mean, they want to be part of research, which means that their motivations may be different than people who ignore the opportunity to be in All of Us or Our Future Health. And we're not going to be able to understand what happened to what's going to happen to those people because we can't study them.
Yeah, exactly that, isn't it? It's, these people who volunteer for these things, there's probably quite a commonality, although, and however much you try and do the outreach to go and find those hard to reach communities, it's a challenge, isn't it? So the next question is from, is actually really relates to this. It's from David Ellerman, who says, "Good to hear your population is more representative of the general population." That was to you, Cosima. But do you think health behaviours of the people who sign up for this sort of study are more likely to be health conscious and so not representative, as Geoff just said, perhaps?
It's a great question, and the answer is that is something that most studies of this type will always struggle with. We have a really extensive program of community engagement, where we do activities on the ground across all 4 nations in the UK, particularly within communities where there is historically a great distrust in the health system and a distrust in government initiatives. And so within those communities, often there is low engagement with people's health. So by doing that, we hope to recruit people who are more representative in terms of their health attitudes. However, that's obviously, hard to account for. You could still be recruiting the most engaged within those communities, and so it is something we continue to focus on. I'd love to hear a bit more from all of us about that, actually, because obviously that was a really key focus.
We have, thank you. We've gone an extra yard, if that's the right term, to go and outreach communities that, as I said, are generally not represented in biomedical research. And we've made an effort to oversample those in our population. We've engaged in the U.S. They're called federally qualified health centers that often treat individuals who cannot afford healthcare through more traditional means, and we've had community outreach using things like a mobile vehicle to go to places where we can reach people where they are, so we can achieve more representation of individuals, as I mentioned, that aren't part of biomedical research. How those individuals will respond to. So the good news is that we've had a significant representation of those individuals. More than 90%, or about 90% of our population has never been asked to be part of a biomedical research study. But how they will respond to the information we're giving them as part of how they'll integrate it into their behaviors or as part of their health management is something that remains to be seen from the research that we're carrying out. As I said, it's early days.
Okay, I'm going to move on now to a sort of more practical question from Shamina Rahman, who says, if a participant becomes unwell during the lifetime of the Our Future Health study, will clinicians be able to have access to the results from the whole genome sequence in order to improve the management of the individual in real time? So I think that's one for you, Cosima.
That's a great question. So and I think it's important here to talk a little bit about how Our Future Health differs from an organization such as Genomics England. So with Genomics England specifically set up in order to support diagnosis of genetic diseases and to provide that analysis back to clinicians. So there is although Genomics England also does obviously the newborn genome study and 100,000 genomes, there is a clinical kind of service that they also provide, whereby that those data and that analysis could be available, and it crosses between, as Mike Parker mentioned, clinical and research. Our Future Health is set up differently. So we are purely a health research program, and those, as I mentioned earlier, the kind of feedback we're delivering is in the context of research. We don't have at present the clinically validated pipeline in order to provide clinical data to a doctor, and therefore we wouldn't be providing genetic information to an individual. I think the question really also is, what utility is that? And there are only certain situations where someone is ill and a whole genome sequence would be immediately relevant to someone being acutely unwell. We're looking at how do you use genetics to predict disease before it happens.
Okay. I'm going to move on in the interest of time to a question from Mark Bartlett. It's quite a long question, so bear with me. Genetic panels can certainly appear attractive, particularly in the terms of upfront cost and alignment with current variant knowledge. However, whole genome sequencing offers a more complete and future-ready alternative. While it may initially seem more complex, it provides a lifelong comprehensive resource for the participants, one that can enhance research, support reanalysis as new knowledge emerges, and significantly reduce costs over the time through avoiding repeat testing. With the landscape of genomic medicine evolving rapidly, it would be helpful to understand how our Future Health is approaching return on investment in this context. How is the value of long-term utility, adaptability, and research potential being factored into your plans and evaluation frameworks? So I'll just pause for breath and let you digest that for a moment, Cosima, before you respond.
Yeah, thank you, Mark. It's a great question. We set out at the beginning with genotyping because it was, as you mentioned, the kind of lowest cost option. And we essentially have a custom genotyping array, but we also are conducting at the moment imputation. So essentially able to generate a predicted whole genome sequence from those genotypes. But we are planning to include other aspects like whole genome sequencing, exome sequencing, etc., to augment the data set. So that's very much within our plans. But as you say, this is a constantly evolving space. The cost goes down, the technologies improve. So it is something that we'll continue to do over the lifetime of the program, and we'll also be thinking about additional samples and additional blood samples in the future potentially as well.
And Geoff, is this something you've thought about, all of us?
Yes, I would say all of us. Well, first of all, I believe I fully agree with the question that the goal should be sequence once and use often. So you amortize the cost of a genome over the lifetime of a patient or participant. All of us does not return whole genome information to anybody on individuals. We do return results that I've shown you, but we're still at the ACMG 59, even though the ACMG list has grown to 84. So we haven't even begun to expand the repertoire of potential actionable results that we have, because we have other priorities right now, but that we feel comfortable with that. It is fully within the realm of possibility that a participant can request their raw data from us on their genome, and we've had that request about a half a dozen times out of the 800,000 people. So it's not a very large number, but we haven't released that information. But I imagine that we've sequenced somebody's genome, we give them the information, and they have it as a portable asset that they can bring to their healthcare provider. That might be one of the ways to maybe do a little bit of an end around of our current situation, but we're not in the business of providing long-term results from whole genomes on individuals.
Great. And I'm just going to sneak one more question in. Again, if it's for you, Cosima, but it is an event about our future health. Catherine Ramsey says, what Geoff mentioned on pharmacogenetics could have immediate utility to individuals and their healthcare provider, but it's not mentioned in our future health. Is it planned?
Great question. We do want to return pharmacogenetic information. I think this speaks to two things that are different between us and all of us at present. One will change. All of us, as you mentioned, Geoffrey, you've been at this for longer than we have and have a developed, mature strategy and approach for clinical use of your data, whereas we are at the beginning of this journey. So, pharmacogenetic data, we need to ensure that we are in that right position from a regulatory perspective. And the second piece is that the ecosystem into which we're delivering feedback is very different to that in America. And to some extent, I'm slightly envious of the kind of flexibility that you have with the multiple different providers, and of course the kind of the model of healthcare where an individual has coverage and can go to someone with data and get a new test. In the UK and the NHS, we have to be very careful of placing additional burden on our already creaking health system. We're set up in order to, develop new ways to reduce that burden, not to inadvertently create it by our activities. And secondly, the NHS would probably want those data integrated into a health record, and that is another piece of work that we'd need to do as part of that. So watch this space. We're really keen to make that happen. It's just a little more complicated in the UK to make it work effectively.